Hi, this is Dr. Joannides, Chief Medical Director at Optimum and this is the Optimum Academy Breast Cancer 101 video number 3. And this is about the new underwriting risk score feature. So let's get started. So our new manual update on breast cancer includes something called risk scores. And it's a new feature that only Optimum has. And it's based on science and something that you should pay attention to. It may set us apart from all the other underwriting manuals that you might come in contact with, and it may be very useful to you in the future when you're trying to determine the mortality risk of somebody who has had breast cancer in the past. So let's take a look at what this is. So the key about this risk score, a new feature, it uses the grade of the breast cancer cells, the ER and HER2 status to determine what this risk score really is. So here's how the risk score works. So you give 1 point if any of the following are present. The more points, the worse the score, the higher the risk. So you get 1 point if the grade of the cells are described as high grade or poorly differentiated or undifferentiated, or the SBR score is 8 or 9. And we'll talk about that in a minute. You also get 1 point if the ER or estrogen receptor status is negative or unknown. So if the estrogen receptor status is reported as negative or it's not reported, you don't know what it is, you also get a point for that. But you do not award this point if estrogen blockers are being given and the estrogen status is not documented, since you would only use estrogen blockers like tamoxifen if the ER status was positive. Also, you can get a point if the HER2 status, HER2 status is negative. So if the HER2 status is negative, you also get a point. If HER2 blockers have not been used or the HER2 status is not known, that would also include giving a point for the HER2 status. So the risk score that we're talking about here may range from 0, no points, to as high as 3 points. And that's the whole risk scoring portion of our underwriting update for breast cancer, but very important. So we're going to talk about all the elements that go into the risk score. So the hormone receptor status is key. And breast cancer specimens are tested for estrogen receptors, progesterone receptors, and HER2 status. So when you see a pathology report and they include these studies, take note of whether the estrogen receptor or progesterone receptor are positive or negative, and what the HER2 status is. When in doubt regarding any of these factors, if you're confused or not sure which way to go, refer to the medical director. Just a word of caution: when triple negative breast cancers are present, in other words, the estrogen receptor is negative, the progesterone receptor is negative, and the HER2 is negative, those are unfavorable breast cancers and more worrisome. So at your leisure, you can look at all the things I've highlighted in yellow here, which should help you understand how to assess the hormone receptor status of breast cancer. So here are some key points that flow into this risk score. So about 80% of breast cancers are estrogen receptor positive. In other words, you would not get a point for those. About 13% of breast cancers are estrogen receptor positive, but progesterone receptor negative. You don't get a point, but I just wanted to let you know that the mortality is slightly higher in these cases. About 2%, so a very small portion, the estrogen receptor is negative, but the progesterone receptor is positive. In that case, because the estrogen receptor was negative, you get a point. So that would increase the risk. If both the estrogen receptor and progesterone receptor are negative, you get a point because the estrogen receptor was negative. And then hormonal therapy may help slow or stop the growth of HR-positive breast cancers by lowering your body's estrogen levels or blocking the effects of estrogen. And we'll talk more about that. So here's a big word, heterogeneity. In other words, a mixture of estrogen receptor and progesterone receptor hormone status. Not all or none. So the Allred score, named after Dr. Craig Allred, combines the percentage of positive cells and the intensity of the reaction of the cancer cells in regard to the receptor status. So it's kind of like on a graded scale. So when you're trying to figure out is somebody estrogen receptor positive or estrogen receptor negative, it's not an all or none, it's on a percentage basis. So you can see that when the receptor status is evaluated, it depends on the percent of positive cells and the intensity of the reaction, whether it's positive or not. So this is part of what's called the Allred score, in case you ever see that. So you can see in the table at the bottom, the proportion score based on the number of positive cells, the percentage of positive cells, and the intensity, and what the score based on, or the Allred score would be based on. So an Allred score of 0 is the weakest, and an Allred score of 9 is the strongest. So here's a real case regarding estrogen receptor and progesterone receptor Allred scores. And this came right out of a case. So if you read the top portion, it says the hormone receptor studies are done and the results are as follows. The ER, estrogen receptor using rabbit monoclonal antibody, was positive, moderate to strong intensity. 60% of the cells reacted positively. For PR, progesterone, it was also regarded as positive. It said moderate to strong intensity, 50% of cells were positive. Then for HER2, it said equivocal. So kind of a wishy-washy score of 1 to 2. So they're not saying yes and they're not saying no, so it's kind of in-betweener. So if we look at the way to rate this particular case for the estrogen score, you'll notice that in the box at the bottom, because the estrogen was reported as moderate to strong intensity and 60% of cells were present, you add the two scores together, and in this case you get a final score that is showing that the estrogen receptor is positive. Now, on this varying scale, scores of 0 to 2 are considered negative, and scores of 3 to 8 are considered positive. So you can see that when somebody is called estrogen receptor positive, they could be anywhere on that scale between 3 and 8, depending on the intensity and the percentage of cells that are positive. Now, what do tamoxifen and aromatase inhibitors do? And these are called selective estrogen receptor modulators, or SERMs. So estrogen blocks, I'm sorry, tamoxifen blocks estrogen receptors. So when you take that drug, it blocks the receptor, so estrogen cannot land on the receptor and cause its effects. So drugs like Nolvadex, or tamoxifen is the generic, they block estrogen receptors, which either slows the effect of any cancer type cell or prevents the estrogen from having a developmental effect on any potential cancer cells. So it's a blocking drug that hopefully helps prevent future cancer cells from occurring. Aromatase inhibitors block an enzyme that inhibits estrogen synthesis. So it works in a different way to block the effect of estrogen. And I'm going to show a little bit more about that. And at the bottom, I've listed 3 of the drugs that you may have seen in APSs that are aromatase inhibitors. So tamoxifen works by blocking the effects of estrogen on hormone receptor positive breast cancer cells by sitting in the estrogen receptor on the cells. If tamoxifen is in the receptor, the estrogen can't attach to the cancer cell and the cell doesn't receive estrogen signals to grow and multiply. However, tamoxifen won't work on hormone receptor negative breast cancer, so there's no sense giving it to estrogen receptor negative breast cancers. Aromatase inhibitors are 2 types: the irreversible steroidal inhibitors. So the first is EXEMESTANE. It forms a permanent and deactivating bond with the aromatase enzyme. So it irreversibly blocks the steroid. And the second type is reversible non-steroidal inhibitors, like anastrozole, which is more commonly used. And these are reversible, so it's not a permanent bond, but it still has the effect of blocking the ability of the cancer cells from growth. So here's a quiz. What percentage of women have HER2 receptors on their cells? So take a second and think about this. And as you know, my quizzes are usually designed so that it may be something that you would otherwise think of a different answer than is the correct one. So actually, the correct answer is D. So you say, wait a minute, I thought only some people have HER2 breast cancer. But here's the actual story. So in normal cells, HER2 is present. So you can see the picture on the left. You can see that there are HER2 receptors in normal amounts, and this results in the normal cell growth and division. However, people that have HER2 positive cancer cells have too much HER2. So too much of a good thing causes cells to grow and divide too rapidly. So this epidermal growth factor receptor protein is involved in cell signaling pathways that controls cell division and survival. Sometimes mutations, changes, cause epidermal growth factor receptor proteins to be made in higher than normal amounts on some types of cancer cells. So when this HER2 gene is overexpressed, there's a larger amount of HER2 present, and this may allow the cancer to spread. So the treatment is called Herceptin, which is a monoclonal antibody which is given to block those HER2 receptors. So you can see in the picture at the bottom, let's say normally you just had the receptor, in normal amounts. And what happens with the Herceptin is it's a monoclonal antibody. It's those little Ys that actually blocks the receptor so that the cancer cells don't get that stimulation to grow. So here's just kind of a distribution of the hormonal subtypes that are involved with what we're doing with these risk scores. So you can see that by far the greatest percentage of cancer is hormone receptor or ER receptor positive and HER2 negative, and that's 73% of breast cancer. So that's the big pink area. And because the the ER is positive, estrogen receptor is positive, so HR is positive, hormone receptor positive, you get a point for that. Because because it's HR, the ER is positive, you don't get a point. However, because the HER2 is negative, you get a point. So in most cancers, you're going to get 1 point. The next largest group is the 2-point group, where it's hormone receptor negative and HER2 negative. For that, you get the most points, or 2 points, regarding estrogen receptor and HER2 status. So you get a point because both of those are negative. The third group, where you get 0 points, is where both estrogen receptor or hormone receptor is positive and HER2 is positive. So in that case, you get 0 points since neither were negative. And then the smallest group is hormone receptor, which is ER receptor negative, and HER2 positive, where you would get 1 point. So you can see by far most breast cancers using our risk scores are going to get 1 point. The next largest group is going to get 2 points, and then the third group is going to get 0 points. So this helps show you the distribution using our risk score. So this may sound confusing when you first approach it, but the more you use it and get comfortable with this risk score calculation, the more helpful it will be in trying to assess risk. So for people with hormone receptor positivity and HER2 positivity, both positive, 0 points. So those are the best cases. So hopefully this is helpful, not confusing. So what do you do if somebody is HER2 positive? And why don't we give a point for that? It seems like that would be worse, right? But because Herceptin therapy works so well as a monoclonal antibody to take care of this, we don't give a point when somebody's HER2 positive. We only give it when they're HER2 negative. So when you see an APS report and you look carefully, you have to kind of dig sometimes to see if the applicant has been treated with Herceptin. Herceptin treatment is usually for 52 weeks, a year. So doses are given every 3 weeks or whatever time period to complete a year's worth of treatment. So even if you don't see if somebody is HER2 positive in the APS, if they've been treated with Herceptin for a year, they were HER2 positive. So in that case, they don't get a point because they're HER2 positive and they got treated. They only get a point if they're HER2 negative and you don't know what the status is, or you don't know if they ever got treated with Herceptin. So what's a monoclonal antibody anyway? So if you can see to the picture on the left, these things that look like Ys, these are designed genetically to act like an IgG antibody. So they're designed to look like our human antibodies, but they have a predilection for HER2 receptors. So they're like grown and they all look the same. So it's monoclonal or one clone to block the HER2 receptors. So when you get the dose of Herceptin, that's what it's doing. It's sending these little Ys out into the body to attach to tumor cells on the HER2 receptor when that test has been determined to be positive on the breast cancer sample. And then just for your own interest, I threw in what other kind of antibodies look like. So when you hear of an IgM antibody, it's actually 5 Ys connected together. And then IgA antibodies can be 2 together, single, or 3 together. And then IgD and IgE are singles. IgE is involved with allergy. So you've probably heard of in asthma, some people have high IgE levels. Immunologists would treat those kind of conditions. So that's what all the different antibodies look like. We're concerned here with the IgG, which is actively used to treat HER2 disease when it's made in a monoclonal fashion. Now, there are drugs in addition to Herceptin that are called biosimilars, but usually Herceptin is the most frequently used. But as it goes off patent, I'm sure there'll be other types of drugs used that are similar, if not the same, generic medication. But when a drug ends in MAB, the MAB stands for monoclonal antibody. And here's what it does. So if you look at the picture at the top, here's how Herceptin works. HER2 molecules on the surface of the cancer cells pair up to send signals that encourage the cells to multiply and call out to blood vessels for help. So the cancer cells want to grow and it's sending out signals for help to grow fast. So what does the Herceptin do? It actually can use to block these signals for multiplying and calling out for help. So those Ys attach to the receptors and they block this from happening. So hopefully they slow the growth or block the growth of cancer cells. So hopefully this is helpful. So let's kind of summarize now this risk score business. We spent a lot of time in the weeds here trying to establish why are we doing this. So the new cancer staging using the AJCC 8th edition included a lot of parameters to assess the risk of breast cancer. Fortunately, we had somebody to help us out and to use a more simplified fashion of kind of assessing the risk of all these characteristics of breast cancer. And so this person came up with a risk score, and her name was Mariana Chavez McGregor. So it's incorporating tumor characteristics to the American Joint Committee on Cancer Breast Cancer Staging System. So because the staging is so complex otherwise, she came up with this like more easily to understand risk score system. So she noted that the most favorable outcomes were seen for hormone receptor positive tumors, followed closely by HER2 positive tumors, with the worst 4 risk groups within each category noted by the risk score that she was using. So here's the risk score using the grade, ER positivity or negativity, and the HER2 status to determine the risk score. And as we went through before, you get 1 point if the grade is high or poorly differentiated or undifferentiated. You get 1 point if the ER status is negative or unknown, and 1 point if the HER2 status is negative. Thus, the total risk score may range between 0 and 3. So this is Dr. Chavez McGregor, and these are the components just as she wrote about them in the Journal of Breast Cancer in 2019. So basically, our breast cancer underwriting guidelines have used this risk score as part of our determination of what the mortality risk is when a woman has or man has breast cancer. So you can see we used exactly the same score system that she designed using the tumor grade, the ER status, the estrogen receptor status, and the HER2 receptor status as well. So the reason this is important is that mortality risk in breast cancer is nonlinear, meaning there are certain factors which really zoom up the risk. And those are things like up at the top right, the younger age when woman has breast cancer, larger cancers, many nodes involved, ER negative or triple negative if BRCA mutations are present, grade 3, in other words, a poorly differentiated or undifferentiated cancer cell status, and then if somebody has just had recent treatment, the risk remains high for a period of time. So as I said, it's nonlinear, and any of those circumstances put the person at higher risk, which would require either a higher rating or we would be unable to take that candidate for life insurance at the present time. And just a little more about this grade that I had talked about, the grade of the cells. So that, what does that SBR that I talked about actually represent? And that's Scarf-Bloom-Richardson, or the Nottingham histologic grading system. So if you see SBR or Nottingham, and you can see what the difference is between grade 1, which is low grade, and the score is 3 to 5, grade 2, which is score of 6 to 7, or high grade, which is score of 8 to 9. And if you'll notice in the pictures, as you go from left to right, the cells look a lot more angry, especially in the far right picture, and all the characteristics look more aggressive when you look at the pathology slide compared to the slide to the far left, where there was more of a normal looking pattern to things. The things that are abnormal are the nuclear grade, how fast the mitotic rate is, and whether there's tubule formation. The more tubules, like on the far left in the lower grade, the better. The smaller number of tubules, the worse the prognosis, which is in the picture to the far right. So the way we use this risk score is after we get the stage of the cancer, we then partition off that stage along with the different risk scores, 0 or 1, whether the risk score is 2 or the risk score is 3. And you can see that it puts people into different prognostic groups. And the higher the group number, the worse the risk. And so this breast cancer staging, although it may seem complex now, it's very useful when you have a complex breast cancer case and you can use the stage, the risk score, and then put people into the appropriate prognostic group. So it makes a big difference, obviously, on what the breast cancer stage is, but also if you notice that risk score, when the risk score is higher, it really bumps up what prognostic group that the person falls into. And if we had a particular case to go over, we could show that obviously the higher the risk score, the higher the rating is going to be, even within the same stage. So, as I said, it makes a big difference what the risk score is. So 0 to 1 point is our lowest risk group. 2 points would be higher and a higher prognostic group, and then 3 points is the highest risk group and would offer the highest rating if we could even consider that person with that higher risk group. And so our ratings are stacked based on these findings. And I covered the actual ratings since some people that are viewing this may not have access to our manual. But the actual ratings are for each stage and grade and prognostic group. And so if you use our manual, it will be self-evident at the time that you're actually trying to underwrite a particular case.